Good afternoon, ladies and gentlemen. Welcome to CHSRF On Call. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press star, then 0. Web participants requiring support should select one of the tech support options at the bottom of your screen. I would now like to turn the meeting over to Stephen Samus, Vice President, Programs at CHSRF. Please go ahead, Mr. Samus.
Thank you very much. Hello and welcome to CHSRF On Call, which is an interactive series by the Canadian Health Services Research Foundation. CHSRF On Call brings together policymakers, healthcare executives, researchers, and the public, and you to be part of a dialogue about ways to improve healthcare for Canadians. We're also pleased to now offer new and improved connectivity options for our entire audience, including new web streaming with integrated audio and video, allowing participants to listen through their computer speakers. We're also pleased to now offer simultaneous interpretation for our French audience members. If at any time during our session you experience technical difficulties, please choose one of the tech support options at the bottom of your screen. As you heard, my name is Stephen Samus. I'm Vice President of Programs here at CHSRF. It's a pleasure to be here today. Welcome to today's call, where we're exploring options for reforming generic drug pricing in Canada. This session of On Call focuses on two options for generic drug pricing: the implementation of a sliding scale and using tendering systems to reward producers while better aligning payment with production costs. Today, we're very pleased to have with us Aidan Hollis, Professor in the Dept of Economics at the University of Calgary, and Matthew Brougham, Vice President, Products and Services at the Canadian Agency for Drugs and Technology and Health, otherwise known as CADTH, here in Ottawa. Matthew is a former Chief Executive of Pharmac in New Zealand. Today's call begins with brief presentations from each of our speakers, and then we'll open the lines for a question and answer period, where we'll take questions from you. Instructions for asking questions will be provided at that time. It's now my pleasure to hand over the floor to Aidan.
Okay, so thanks very much for this opportunity to discuss generic drug pricing in Canada. Generic drug pricing has been going almost continuous reform over the past 5 or 6 years. It's hard to think of an area in which there's been more experimentation. So this is certainly a very interesting area to work in. And in this presentation, I'm hoping first to convince you that there is a need for further reform. While recognizing that provincial drug plan managers have done a lot to improve outcomes in the last few years, I don't think we've arrived at a point of perfection quite yet. Then I'm going to talk about some possible reform mechanisms. I'm going to focus on one particular mechanism, the descending price schedule, not because it's necessarily better than the alternative, but because it is less familiar to most people. But we'll also spend a bit of time on tendering. So to advance, here we go. I'm just trying to work this. Okay. Generic drug reimbursement rates for provincial formularies in Canada have traditionally been set according to a scheme in which the province will pay a fixed proportion of the branded drug price. In Ontario, which has led the way, the generic drug price was originally set at 75% of the brand, and then it was reduced to 70%, and then some years later that wasn't good enough, so it was reduced to 50%, and again a few years after that, 25%. It's evident that these numbers are completely arbitrary. In many cases, the generic price is far above the cost of supply, and in other cases, it is below. So it's helpful to remember why it is that we have this system. Ordinary competition doesn't work well in drug markets. Insured consumers don't hunt for drug prices, so pharmacies don't compete on price. When the manufacturers are competitive, they sell at net prices far below the reimbursable price, since they're competing to get their product stocked by the pharmacy. The net result is that even when there's aggressive competition between manufacturers, prices don't fall at the retail level. Evidently, we should be aiming for a system in which the cost savings from competition are passed on to consumers. I'm going to present a few examples of some pricing outcomes, and to do this, I almost at random, picked a few top-selling drugs in Canada and then examined the prices. So this slide shows the brand prices and the accompanying generic prices and reimbursement rates in Ontario as of last summer. Prices in the most of the rest of Canada are somewhat higher, at least for the reimbursable rate. You'll see that for most products, the reimbursement price is around 25% of the brand price. For example, for amlodipine 10 milligram capsules, the generics are priced at around 50 cents, exactly 25% of the brand's $2 price. Then, to determine whether these prices were actually reasonable, I looked for prices outside of Canada. And I didn't have to look far. I looked at the U.S. government's Federal Supply Schedule. The Federal Supply Schedule prices are shown in the column on the right. These are admittedly very competitive prices, but they are very far below Canadian generic prices and probably fairly represent the cost of manufacturing for these products. And what they indicate is that Canadian retail prices for many molecules do not really reflect production costs or the existing competition in supply. So the question to ask is, well, how can we get low prices at the retail level, more like what we see for the Federal Supply Schedule? So what I'd like to do is to propose a simple mechanism that's designed to simulate the effects of competition on price. And the idea is that the reimbursement price for all products would be based on the number of entrants, automatically falling more with each additional entrant. And I provided an example here of what this could look like. In this example, the reimbursement price, if there's one generic entrant, is set at 50% of the brand price. But then if another generic enters, the reimbursement level falls to 35% of the brand. And so on. With each additional entrant, the reimbursement price falls lower and lower. So what's attractive about this system? Firms will enter as long as the reimbursement price is above their cost of production. The result is that the system automatically drives price towards the marginal cost, just like ordinary competition. If costs are high, there'll be few entrants, and the price will also be relatively high. If costs are low and the market's large enough, there'll be many entrants, leading to very low prices. And there are potentially large savings to be captured on some drugs. These are, of course, the high-volume products like atorvastatin, which currently has 10 manufacturers listed on the Ontario formulary. So an important issue is whether this is feasible or not. I think in an administrative sense, it has to be feasible. Ontario, for a long time, had set reimbursement rates at 70% of the brand if there was only one generic, and then when a second generic entered, the price fell automatically to 63% of the brand. That old system simply didn't go far enough, and the proposal I'm making here is simply that we should be extending it more aggressively to get much lower prices. It's also worth noting that Austria has used this kind of system for some years. Another attractive feature of it is that it's relatively easy to try. The proposal could be assessed on one or two drugs and then expanded if successful. Ideally, more than one province would cooperate on this in order to provide stronger incentives for firms to compete. Finally, I just want to comment on tendering. And the slide is titled, "Why Not Just Tendering?" Tendering is attractive, certainly in some circumstances, but possibly not in every circumstance. Tendering, in which manufacturers compete to supply the entire needs of the province, is also clearly effective in generating low prices. But it probably isn't desirable immediately following the first generic entry, since it undermines the incentive to challenge patents at all and may lead to slower generic entry. There are some other issues as well. It may reduce the number of active producers, and that could undermine competition in the long run. But it's clearly preferred to the current system, especially for drugs which have been generic for some years. So thanks very much for your attention. I'm looking forward to an interesting discussion. Stephen?
Great. Thank you very much, Aidan. That's a terrific presentation. We will have an opportunity to discuss the proposal after the next presentation. I'll now turn it over to Matthew.
Thanks, Stephen. And I too would like to thank CHSRF for the opportunity to be involved in this presentation and discussion. I was invited by CHSRF to give the decision makers' perspective, but I have an admission to make. In this context, I'm currently not a decision maker. So, as was pointed out in Stephen's introduction, I'm really relying on my experience as a decision maker in the New Zealand system. And just a little context there, Pharmac was the agency that ran the single drug plan that covers the entire population of New Zealand. So that's the publicly funded drug plan. And in one of its key instruments in managing expenditure under that plan was the use of tendering. So it made extensive use of tendering. Canada pays a lot for generic drugs. Although this data is a little bit old, 2008, it is published widely and is available widely, and really just makes the case quite clear, even when we look at countries where they have regulated price reductions as well. Many countries pay somewhere in the region of 40 to 70% of the Canadian price reduction, so that's not 40 to 70% of the branded price, but of the generic prices that we see in Canada. And if we take the lower bound value here of 40%, then in 2008 alone, we could be saving in Canada somewhere in the order of $700 million, something that I would suggest to you is not to be sneezed at. I think it's fair to say that decision makers are currently faced with ever-tightening budgets, and to pay for new technologies and services, they must find ways of paying less for old technologies. One way to do this is to substitute high-cost inputs with low-cost inputs at every opportunity, and this means that the system can effectively afford more inputs or more new inputs. Put this another way, if you don't subsidize high-priced inputs with low-priced inputs when you have the opportunity, ultimately you can afford fewer new inputs. Patent expiries clearly offer one of those rare opportunities to buy inputs at lower prices. And recently I was attending an HTIR policy forum meeting which has broad representation by the industry, and this is not an idea that only buyers, if you like, and governments are currently interested in. But the industry itself recognizes that if we don't enable ways of making savings in one part of the sector in order to pay for new inputs, then the opportunities for getting new technologies into the market are going to be severely reduced. So most markets use competitive process to keep costs low, and we're all very familiar with these competitive processes where we seek quotes as a very simple process, or we run requests for proposal, or indeed tenders and auctions. These are all very common. The key point about these processes is that they do tend to restrict choice. And this is because they're offering up an exclusive right for somebody to bid for. When we come to the drug markets, we don't seem to do this in most countries around the world. We instead opt for multiple brands, and as a consequence, we tend to opt for price taking. And as a recourse to deal with this, we generally focus on one-off price reductions through regulated price reductions. So why are drug markets so different? I think I'd like to postulate that it's mainly because in Canada, we're concerned primarily or more with acceptability than efficiency. That might sound a little controversial, but I think it's just a consequence of context. In Canada, we're more able to afford acceptability. When you get to little countries like New Zealand, the opportunities to focus on acceptability are much severely reduced. So under the regulatory approach, while it's often controversial when it's being put in place, powerful interests tend to be protected. And indeed, when we look at these approaches, producer surpluses tend to get given a higher value than the equivalent consumer surpluses. To use tendering in Canada, one would have to tackle the controversial consequences of tendering head-on. In New Zealand, I've had to deal with all of these concerns in the past, and I've listed a number of them here just to draw your attention to them. There is no doubt that tendering has a range of consequences. The first, of course, is that you're offering up an exclusive right. To create that exclusive right, you're reducing choices for consumers. Now, you can argue that in many instances this doesn't have a consequence, but it's clear that in some instances it does have a consequence. Often multiple brands of the same molecule are in fact identical. They simply have different packaging. But occasionally different brands have different buffers in them and are made in different processes, and so they do have very small differences. And I think we always, when we're in tendering process, have to accept that this is a reality. Another key point that Aidan pointed out was the impact that a tendering process would have on pharmacies. It's quite clear right now that the generic suppliers that compete quite aggressively with one another to get their products on the shelves of the pharmacies to whom they're supplying. The only problem with this sort of competition is that the benefits don't accrue to the buyers or to the payers, they accrue to the pharmacies. There's issues around xenophobia, the fact that most generic supplied in the world are made in India or China, and otherwise countries that are perceived as having poor quality products. Again, I would hasten to add that these sorts of challenges and concerns, when looked at in the cold, hard light of day, actually have no substance to them, and that many of the manufacturing facilities in these countries are in fact superior to some that we see in North America. We do see increased susceptibility to stock shortages, but we see that in all markets. There's no doubt that drug markets have fragile supply chains, and when you have exclusive products, or if you like, sole supply products, then you are susceptible to stock shortages. There are many ways to deal with this, and as I would like to hasten to add, it's not restricted solely to generic products either. It occurs by definition with patented products. You see a situation frequently, and you need to take it into account when you look at any of these mechanisms of doctors and prescribers essentially swapping out the generic products for branded alternatives, and effectively the opportunities for decreasing the cost of your inputs gets lost. And there are a few others I haven't mentioned here. As Aidan mentioned, the effect on patent challenges is a real one, and it's one that has to be managed very carefully. And missed off this list is the impact, of course, on local producers. But as I said right at the start, there are acceptable ways by which to deal with virtually all of these consequences of open competition and, in effect, tendering, in my view. Regulated price reductions are more acceptable but not as efficient. It has virtually none of the consequences that we saw above, and it is, for this reason, I believe, used extensively around the world. In short, vested interests are managed through the political process, and I would argue with relatively costly results. We end up relying on government's coercive power rather than markets' competitive power, and as a consequence, I believe that we end up paying a price premium and losing significant value. And why do I say this? Well, here are some stark examples. Just want to show you some price comparisons of products, and these are public values that can be obtained from the schedules of the various jurisdictions. And for example, simvastatin 40 milligram around $1. That's our best estimate of the cost ex-manufacturer before taxes, so that these numbers are comparable, versus, for example, in New Zealand, that's 2 cents for the same product. And this is on a equivalent dollar basis, Canadian dollars, I believe. Likewise with omeprazole. The interesting one here is metformin, because this is the Apotex product supplied to Canada. It's the same product that's supplied in New Zealand, and we have a price differential here of 11 cents versus 1 cent. So, if open competitive processes are not acceptable to decision makers and regulated price reductions leave too many savings on the table, what else can we do? Sliding scale price reductions are a second best to open competitive processes in my view, but they do have the advantage of ongoing and future benefits occurring from one, possibly controversial, regulatory change. They do this, I think, because their power stems from their impact being generated by individual actors making non-coerced decisions. In this sense, I think they combine the acceptability of regulatory approaches with the efficiency of market-informed decision-making. Thanks.
Thank you very much, Matthew. That's an excellent synopsis of some of the policy options implications of some of the options that have been presented in Aidan's presentation. I'm now happy to open the floor to our audience, and there are 2 ways that you can pose your question. For both English and French participants, you're invited to submit your questions electronically using the questions box located at the bottom of the left of your screen. For English participants only, not connected by a computer, you can ask your question verbally by pressing *1 on your touch-tone telephone. When asking a question, we would ask that you please identify whom you'd like the question addressed, and please try to ask only one question at a time. I'm going to first start off by going to the lines and asking the operator if there are any questions on the phone lines at this time.
Ladies and gentlemen, if you would like to ask a question, please press * then 1 on your touch-tone phones.
And as we wait for any questions that might come in on the telephone, we'll go to a couple of questions that we have that have come through by computer. The first one is, and I think, I can direct this to either of you. It's not specified, but it may be more appropriate for Aidan Hollis. To what do you attribute the lack of price competition at the pharmacy level? How should private payers behave in the proposed reimbursement model? Aidan, do you want to take a shot at that one?
Sure. I think there are two questions there. So the first question: why aren't pharmacies trying to attract consumers by lower prices? I think the answer is that most consumers are already heavily insured. So the result is that they aren't really sensitive to prices. Because they're not sensitive to prices, they don't go hunting for low prices, and in any case, it's their pharmacies stock so many different products that it may be difficult to sort of demonstrate that one is actually cheaper on everything or on the relevant set of products. But I think that the key one is that consumers aren't paying for the product or not a large share of the price, and so they simply aren't really sensitive to it. For private payers, the situation is even worse than for public payers. Private payers tend to be completely undiscriminating. They are paying higher prices in Canada, typically, than public payers in most provinces, which is why Ontario has recently been moving towards having the same prices for all payers as for the public payer. The implications of these high prices are that, first of all, the provinces should be looking to try to impose the same prices on everyone and not have exceedingly high prices, I think, for private payers who tend to be poorly protected.
Thank you very much. I think I'm going to ask you, Aidan, if you could answer a second question here that's been identified for you, and that is, what do you envision to be the impact of the descending price schedule on Canadian generic manufacturers and their ability to compete with multinational generic manufacturers and providers operating in the Canadian drug market?
So the impact of the price schedule on the manufacturers should be relatively small. And the reason is that currently the way that manufacturers are competing is in fact through providing products at lower prices than the nominal price at which the product is being sold by the pharmacies. So manufacturers are currently paying substantial rebates. And so and essentially they're competing through those rebates to pharmacies. Even though rebates are not allowed in some provinces, they're allowed in other provinces. And the manufacturers are naturally operating on a national scale, and many of the pharmacies are also operating on a national scale. So banning rebates in one province probably doesn't have a large impact on manufacturer behavior. In terms of the competition with the international manufacturers, all the manufacturers in Canada are international. So there is, I guess, Apotex is domestically owned, and as such might be thought to be a sort of Canadian manufacturer, but it operates all over the world. And all the other manufacturers, as I understand it, are, or pretty much all the other substantial manufacturers are in fact, international.
Great, thank you.
Yes, can I comment there?
Sure.
Stephen, I was just going to say to that last example I had in my slide comparing metformin prices. I mean, just to iterate Aidan's point, Apotex is competitive internationally. It competes very effectively in some markets in New Zealand. So and that market is exposed to quite strong international competition as well. So I think it would be a little hasty to conclude that you would disadvantage significantly Canadian manufacturers just by opening up to price competition.
Yeah, thank you, Matthew. That's an important point. And maybe picking up on this a little bit, the question from one member of the audience saying, do any provinces have a better system than others, I'm assuming, and why is there no central body for all Canadian provinces to pay to get better pricing?
I think that'll have to be one for Aidan, because I've been in this country only a few months. So,
Aidan, as you've looked at the various policy frameworks across different provinces, and you've identified some of the changes that Ontario made, and we've looked at even some of that data that Matthew provided at the end of his presentation on New Zealand versus other Canadian jurisdictions. What's your take on that question?
So in terms of the comparison across the provinces, there's been a kind of continuous ratcheting down of prices in the past 2 years. Ontario was essentially setting the price for everyone, and then they dropped to 50%, and then Alberta dropped to 45%, and BC went to 35%, and then Ontario's gone to 25%. So in terms of who's getting the lowest prices right now, it looks as if Ontario is the current leader, but all these provinces have very similar systems, and it's just a matter of what percentage the price is being set at. So it's not clear to me that one of these is better than another.
Thank you. A question for Matthew Brougham from one of the members of the audience. The question is, don't we need to take into consideration costs of production figures, salaries, corporate taxes, consumer purchasing power, etc., when we compare generic pricing between countries?
No, I don't think you do. I mean, what you need to take into account is the prices that get revealed through competitive processes. So, I mean, at the end of the day, it depends a lot on how you open up the market to competitors. So, I mean, if you really wanted to, you could try and run a competitive process through in North America. I mean, if you wanted to take account of those effects because you thought they might be deleterious on production and local suppliers, you might open up your competition to local suppliers only, or you might open it up to North American suppliers only, or you could choose some other group. But I would hasten to add that I don't think that that's going to be ultimately too great a problem.
Thank you, Matthew. Question here for Aidan. How can we ensure that reduced protection to generic companies as a result of less attractive reimbursement policies will not cause further reduction in the national pharma industry investment and therefore further negatively impact our life sciences sector?
So I think this question is predicated on the idea that the manufacturers would be substantially harmed by lower prices. And I think the observation that I made before is that the manufacturers are already competing, but they're competing through passing on rebates which are captured by pharmacies. So I wouldn't expect a substantial change in the profitability of manufacturers under a descending price schedule.
Thank you. Just going to the operator, if there are any questions on the phones?
There are no further questions at all on the phone lines. Please continue.
Okay, thank you. I have a question here for you, and that would be maybe to Aidan again. What approaches are adopted in other countries toward generic drug pricing? And when you look at that, does anyone stand out as a leader? I know you mentioned Austria in one of your slides, but does anyone stand out as a leader in finding that balance between keeping prices down but adequately encouraging entry for generic drug manufacturers?
That's an interesting question. So the issues of entry for generic manufacturers really depend a lot on the structure of the patent system in each country. So Canada happens to be unique in its set of intellectual property protections. Mm-hmm. You wouldn't expect that it's going to match up to any other country exactly. New Zealand has been very successful in achieving really low prices by a fairly sort of aggressive competitive approach to obtaining low prices. The United States has worked hard to generate early competitive entry by providing a specific reward for the generic that successfully litigates, and they have a 6-month exclusivity period, which is a kind of a reward for the first generic to reach the market. In which, and during that 6 months, no other generic can enter. I don't think other countries have matched that kind of incentive mechanism. But when you look at how quickly generics get to market in Canada and the United States, the effect of that mechanism isn't really obvious. And the reason, of course, is that the entire patent system is different.
Great, thank you.
If perhaps I would just add to that, if we're concerned about market entry by generic players, again, I don't see that the tendering approach that New Zealand adopted and is still using has restricted market entry in any way at all. Prior to the use of tendering in the generics market, there were probably in the order of 10, maybe slightly less, generic companies supplying New Zealand markets. After the tendering process, there were, in the order of 20 to 30. So it's. I think there's pretty strong evidence that if you open it up to competition, you will have a range of suppliers try and enter. I'm not sure if that's what the questioner was getting at, but certainly the evidence I've seen is exactly that it tends to encourage entry, not discourage it.
Interesting. And maybe if either of you want to take on this question from a member of the audience, which is, do we have any estimates of the cost of developing generics by industry? Which I'm assuming the part of the question would be then, to what extent what impact does that have on how you set the reimbursement price?
I think it depends a lot on the product. So some products are clearly more expensive to develop, and it depends on the technical sophistication of the product. Merely running the bioequivalence tests tends to be not terribly expensive. Litigation costs in Canada can be expensive in some cases, running into the millions. And in many cases for these products, they're actually developed really on an international basis. So the chemistry and manufacturing work, I think, is actually done for the global market, not just for Canada.
Thank you.
Yeah, I think the key issue here is, again, that with the signals well in place and contracts in place for reasonable periods of time, then manufacturers have an opportunity to recover their costs in any of these situations. And when we run open processes, we tend to reveal the prices that manufacturers can supply at. There's not that many manufacturers. I mean, I can imagine some instances where manufacturers will offer a price almost below or at cost of production and put themselves in a very, very difficult position just because of the market dynamics. But I think those situations arise pretty rarely. So as long as, whereas the opposite of regulating a price reduction, particularly on a molecule that is very costly to produce, could very easily put you in that situation quite unwittingly, just because of the arbitrary nature of setting that price reduction. I think if you keep the processes open, in the long run, you will reveal prices that are close to cost of production, but above it, to allow something in the market for suppliers to be in there.
Mm-hmm.
So, and that has to be the case since firms don't want to supply below
Correct.
their cost of production.
That's correct. Yeah.
Okay. Following on that, Aidan, another question from the audience. To what extent do Canadian regulations on form of generic products and their packaging reduce competition in the generic market?
So I think that's actually an important point. So when we're comparing across international prices, typically the lowest international prices tend to be for little white pills, which look identical to all the other little white pills. Whereas in Canada, we do have typically same size, shape, and color of the generic pills, so that they resemble the brand product to reduce consumer confusion. So it's clear that there could be additional costs to getting set up to produce a particular size of and shape and color of pill, which would increase the costs per pill somewhat and make it less feasible for the sort of international manufacturers who aren't particularly interested in the Canadian market to participate. So it does require, I guess, some commitment to the Canadian market and a flexible manufacturing capability. Having said that, the pricing differential that we observe for all these products is not reflecting the extra cost of manufacturing a pill of a certain size, shape, and color.
One question we have from a member of the audience is, what would be the impact of having a pan-Canadian drug purchasing entity? Matthew, without editorializing one way or the other or forcing you into that position of whether you would advocate for this as good or bad, but perhaps drawing from your experience in New Zealand, well, how would you answer that question? What would be the impact of having a single purchasing entity?
Well, I think you would get stronger pricing competition as a result, because you would have an entity that couldn't be played off against other entities, as tends to be the case currently. Depending on the mechanisms that you use, and just by having a pan-Canadian drug plan or drug management authority doesn't mean that you're necessarily going to go down the tendering route. There are lots of, as I hope we've made aware today, there are various issues that you need to take into account, and it's not a we will go down this route and not another route. But effectively, you will, with some of these instruments, tend to create some degree of restriction and choice as a consequence. And I think this is probably the biggest issue that has to be dealt with. The upside, of course, is the one I alluded to in one of my slides, where you can reinvest these savings in other forms of healthcare. And I think this is probably the greatest problem that besets us currently, particularly in times of budgetary restriction. What tends to happen in these periods is there tends to be a reduction in the speed at which one can adopt these new technologies, some of which can be quite advantageous. So you kind of limit yourself quite dramatically if you can't take the savings that you can get through price competition and redistribute them towards higher value, newer technologies. So, I mean, ultimately, I think you would see some benefits overall, but to be absolutely clear, not without some consequences that some would consider negative.
Thank you. There are a couple of questions in here that relate to the pharmacy industry itself, and maybe Aidan, this is one. At least we'll start with this one for you. To what extent has consolidation in retail pharmacies into major chains impacted the competitiveness of the market? A follow-up question on that is: do we have too many pharmacies in Canada?
So I think I don't know the answer to the first question. The impact on competitiveness of the increased number of chains. It's clear that those national larger players are more sophisticated, and they have more opportunity to operate, I guess, in ways that they have more efficiencies potentially, but they also I think, are better able to make sure that they operate in ways that are going to be most efficient for them. And I guess as to the question of whether there are too many pharmacies, we do have quite a lot of pharmacies compared to many other countries. And there's a very interesting study done by Mike Law and colleagues at the University of British Columbia, which looked at the number of pharmacies and what would happen if the profitability of the pharmacies were to fall. How many pharmacies could be expected to close, and what the impact would be on the closeness of the average pharmacy compared to consumers. And what that research found was that if there were a reduction in the number of pharmacies because there was simply less surplus available for them, the impact on consumers in terms of having to go further to pharmacies probably would not be very large. We tend to get a reduction in the number of pharmacies that were very close to each other.
Yeah, I think you can. I mean, I haven't done this research, but I think it's an easy enough test to do. If you walk down any high street in any of the large cities and count how many pharmacies are on them, it's kind of an indication that we're probably over-pharmacied.
We certainly see that in some parts of our cities. There's a follow-up question here around pharmacies that we'll go to now, and that is, why don't or can't major pharmacy chains simply buy their own generic company and supply themselves, and therefore have an advantage on the economics, for example, white label OTC drugs and generic? Didn't a Quebec pharma chain initiate something like this a few years ago? And in follow-up, is this happening in the U.S. or elsewhere? I'm not sure which of you would like to take a stab at that one.
So I think there is, in fact, a generic manufacturer in Quebec which is owned by a pharmacy chain. Ontario's been fighting a battle to avoid having this happening in Ontario, with the idea that they didn't want to have rebates being paid, and having the manufacturer own having the pharmacy chain own the manufacturer would be effectively an end run around the ban on rebates. So would this actually lead to any savings? I don't really see why it would. It would lead to exactly the same kind of incentives as we currently have. That is to say that the integrated pharmacy/manufacturer would still have the same incentives to charge relatively high prices compared to the cost of manufacturing. It wouldn't increase competition, and it wouldn't lower prices for consumers. Or at least on the face of it, I don't see any reason why it would.
Thank you. Aidan, I'm going to follow up with, if you don't mind, with another question from a member of the audience here related to the industry. How do direct-to-consumer advertising regulations in Canada relate to your proposed approach to changing the structure of the generic market?
I don't think they really do. The restrictions on direct-to-consumer advertising possibly make it difficult to have effective price competition between pharmacies. I mean, that might be, I guess, the link.
Right.
I can offer a thought here. New Zealand has direct-to-consumer advertising. It's the only other country apart from America in the world that does allow direct-to-consumer advertising. I don't believe it's had any significant impact on, if your objective here is to get better pricing for generics, I don't believe it's interfered with that in any way. But what it may have interfered with to some extent, is one of the consequences I referred to in my slide is the substitution effect. So because the generic manufacturers obviously are not developing large marketing campaigns and marketing forces to go out there and sell their products, you do have to worry about that effect that the branded products can create, where they suggest the substitution of a newer brand through their direct-to-consumer advertising, etc., in replace of the generic product. So I think there can be a bit of a link there, but as I say, I don't think it's had a particularly dramatic effect on the introduction of good price reductions.
It's an interesting point in the market where you have previously been. Matthew, with you, one question here. I think this may be our final question. You mentioned the importance of choice. In the course of your presentations, you mentioned the importance of choice as an issue in tendering. How much does choice matter to consumers of generic drugs when they are insured?
I think it still matters because, it's a very good question, but I think it does still matter because I think fundamentally what we're talking about here is the consumer patient being confident that the product that they're using is effectively the same as the one they were using last year, or is of the same quality, is likely to do the same job. So choice can be a problem because when you set up a tendering process, particularly if you're running a sole supply process, then from period to period, when you re-tender this market, you can end up with a different supplier and a different looking product as a result. Of course, that depends on many different rules that you might have, and Aidan just talked a minute ago about the branding and pill colouring and pill size and look, etc., rules that you have in place here. But that, I think, is where the consumer feels the effect of different choices being made by effectively the manager, and so it is an issue. And for some, you definitely have to have ways to deal with the consequences that throws up. Some patients do have idiosyncratic responses to changes, and they are real, and you have to deal with those. Others, it's really a matter of getting good information out there and educating people that these are, in fact, the same product. They're just different brands of the same product. So, yeah, I think even in an insured market, you can get consumer resistance to the changes in the product. Although, certainly from discussions I've had with people in HMOs, they seem to have less of that when they change brands, etc., on large scale populations.
Thank you. I'm going to try one last question here. We'll sneak it in quickly. I think probably a question directed to Aidan. What is the framework for generic prices in Europe? And if it differs from Canada, why does Canada maintain a regulated price structure?
So Europe is a really big place. They've got many different systems, and including different systems, including different kinds of insurance, and entirely different structures in a number of respects. So even if we think that one of those systems is likely to be looks particularly attractive in its domestic setting, you have to be careful about just assuming that it can be applied automatically to Canada. And I think that's also true of the descending price schedule that we've been discussing. We do have unique institutions here, and we have to be careful about exactly what's applied and whether we can just move what's been successful in one institutional setting to another.
Great. Well, thank you. I think that's actually a really good way to close the session. I'd like to thank you both very much for an excellent session today, both Aidan Hollis from the University of Calgary and Matthew Brougham from CATA. Thank you so much for joining us today. To all of those of you who are online, we hope you'll join us for future sessions of CHSRF On Call. For more information on the full lineup, you can find that at www.chsrf.ca/oncall. We'd also encourage you to sign up for our electronic newsletter at CHSRF, which you can also find on our website and sign up for on our website, which will keep you up to date on all of our activities, including future sessions of On Call, but also other reports that we have coming out, like the report that predicated this On Call today. Just a reminder that you can download today's slides by clicking Download Presentation on the bottom of your screen. And we also would greatly appreciate your participation in a brief survey about today's call. And links to that survey will be sent via email in the next 24 hours. So again, thank you to our speakers today for a terrific session. Thank you to audience members for tuning in and asking terrific questions of them. That concludes our call for today. I'm Stephen Samus. Thanks very much. Have a nice day.
Thank you. Ladies and gentlemen, this does conclude your conference call for today. We thank you for your participation. You may now disconnect your lines and have a great day.